Bree, can you hear me?
Yep, I hear you.
Okay. Can you still hear me?
Yep, sounds good.
It works. Sure, if everyone hands it in. I got it.
Let me save it as a document, so that's why I just sent you the answers. I tried.
You couldn't save it as a Word document?
Yeah, it wouldn't let me. I don't know why.
Did you try taking it, putting it in Notepad and then taking it from Notepad?
I have
Because
no idea.
in my experience, that always works.
Yeah, that's what I thought.
Because Notepad is stripped down. And Word will usually take something that's stripped down pretty much all the time.
So that's why you got it.
Well, it is what it is.
Okay, yes. I stayed at a friend's house. So it was a lot better.
Smart girl. As much milk as her body needs. Why not? Okay, number 4 has got a goof in it. Woman's body will produce as much milk as her body needs. Scratch out body, right on the top of it, milk. Fixed it. Maybe it's better. Very good. Well, hope you guys braved the cold with as much verve, vim, and vigor as you could muster. So we were talking last time about the types of sounds you hear when you auscultate the heart using a stethoscope. Where you place the stethoscope, of course, will be important, but the different types of defects will produce different types of sounds. There are certain types of congenital defects that will shunt blood from the left side of the heart to the right side of the heart. So for example, a ventricular septal defect, because pressure is higher on the left side of the heart than on the right side of the heart, the blood will be shunted from the left to the right. Left to the right shunts are called acyanotic heart defects. Acyanotic heart defects. In some cases, acyanotic heart defects can be asymptomatic. You're taking oxygenated blood, throwing it onto the right side so it gets recirculated through the lungs. The blood that circulates systemically is still fully oxygenated. So you'll have things usually like exercise intolerance, shortness of breath. In the case of infants and young children, there might be problems with feeding, poor feeding and failure to thrive. But you don't get cyanosis. You don't get the skin turning a tinge of blue. If you have a right to left shunt, then you have a so-called cyanotic heart defect. These are more severe than the acyanotic heart defects. They would include things like tetralogy of Fallot, transposition of the great vessels, things like that. Whereas acyanotic would include things like a ventricular defect, an atrial septal defect, patent ductus arteriosus, things like that. And this brings us to a discussion of the electrical activity of the heart. Every time I discuss the electrical activity of the heart, I always get somebody asking me, well, if the heart has electrical activity, can it shock you? No, it can't shock you. It's electrochemical activity. The amplitude of it is lower, much lower than what you would get from a socket. This electrical activity is measured in terms of millivolts. The stuff that comes from a socket is measured in terms of volts. Big difference. One will shock you, the other will not. So as we said, heart muscle cells, cardiomyocytes, they're connected to each other by these intercalated discs that are decorated with gap junctions. You get an ionic change in one cell, it spreads to the other cell instantly. So they work as a unit. They work as a functional syncytium. That means they work as though they were one big cell. Hence the term myocardium. Action potentials that originate in one cell will spread to the others, and they'll spread pretty quickly. If you want to prevent the spread, you have to have non-conductive tissue in between these parts of the heart. That's why you have a fibrous skeleton between the atria and the ventricles. But since you have that fibrous skeleton, it needs to it needs to be spread some other way. So the heartbeat originates in the upper part of the right atrium. There's a special group of cells. They are called the sinoatrial node. They're also called the sinus node. These particular cells have a property called automaticity. What's automaticity? Automaticity means that they self-activate their own beat, which is a pretty neat trick when you think about it. So a cardiomyocyte normally needs some sort of signal to get the threshold, then it depolarizes and it will undergo a contraction. That stimulus is usually its connection to other cardiomyocytes that are themselves depolarizing and going to threshold. These cells don't need that. These cells do it all by themselves. So they will depolarize to threshold in what's called a pacemaker potential. And here's how they do it. So this is a graph of the electrophysiology of those SA node cells. This is not the graph for the usual cardiomyocytes. This is just the graph for the nodal cells. So I'm going to show you two different graphs. Students often look at those two graphs and they say, well, which is it? Depends upon which cells you're talking about. Talking about the nodal cells, this is the graph. I'll show you another graph that is for the cardiomyocytes in general. This graph, that's for cardiomyocytes in general. Don't confuse that one with this one. This is for the nodal cells, the nodal cells only. So if you have this slide in front of you on your notes, you might want to write at the top, SA node only. So you have essentially a channel, and this channel is a sodium channel, and sodium ions can leak through this channel, and they cause this very slow, gradual depolarization. This current is given the term funny current. That to me seems like a really strange name, but that's what electrophysiologists call it. So the pacemaker current, the pacemaker potential, the funny current, what have you, this particular channel is given the name an HCN channel. HCN means hypersensitive to cyclic nucleotide channel. Now, can we all agree that's a mouthful? Can we all agree to just call it HCN? Thank you, thank you, thank you, thank you. So I'll just call it HCN. We'll see why it gets called that in just a bit. But for now, we're going to call it HCN and forget we ever heard about hypersensitive to cyclic nucleotides. Just HCN, okay? Deal? Yeah, deal. All right. So this channel allows sodium ions, which are low inside the cell because of the activity of the sodium potassium ATPase, to leak very gradually into the cell, causing this very gradual depolarization. It will eventually get to the threshold level, At that threshold level, you're going to open these voltage-gated calcium channels. There are two types of voltage-gated calcium channels that will open, so-called L-type and so-called T-type calcium channels. These are sometimes called fast and slow calcium channels. You heard that before? Does that come up in your cardiac when you do your EKG class? Have you got the EKG class? Did they talk about fast and slow channels? No? Okay, well, they're sometimes called fast and slow channels. So if you hear about fast calcium channels, slow calcium channels, that's what they're talking about. Calcium now comes pouring into the cell because calcium levels inside the cell are very low because cells have calcium pumps that pump calcium out of cells so that your calcium level inside the cell is very low. You open a channel, calcium is going to rush in. So both of these are voltage gated. You get the threshold, they open, calcium goes in. Now, you will get to the maximum membrane potential because as positive ions come into the cell, the membrane potential goes from negative to positive. The resting membrane potential is negative because cells pump sodium out of the cell, they pump potassium out of the cell, and they pump in they pump sodium out of the cell, they pump calcium out of the cell, they pump in a little bit of potassium. Plus, there's a lot of negatively charged protein inside the cell. That means you're depleting the inside of the cell for cations. That's going to make the voltage drop across the membrane negative. When you bring cations into the cell, that causes the membrane potential to now become more positive. When you get to the top there, about plus 20 millivolts, calcium channels close, and you open voltage-gated potassium channels. Voltage-gated potassium channels. And there's a couple of these. You may hear the term rectifier channels. Rectifier channels are a type of potassium channel. You may hear other types of things, amplitude channels. They're called K sub R, K sub A, blah, blah, blah. Just voltage-gated potassium channels are there's different types. You'll read about those and they're called different things. They do the same thing. When they get to that high level, they open and now potassium is going to leave the cell. And that will cause the cell to repolarize back down to resting. Yeah. Yeah. L is going to be important later because we're going to study a group of drugs called calcium channel blockers, and that's a channel they inhibit. They don't inhibit the T channel, just the L. L is also subject to regulation through phosphorylation. And because of that, the L channel can cause the pacemaker cell to depolarize a lot faster because of this regulation. Whereas the T-type channels, they're pretty B-flat. They just do their job. We don't do no stinking regulation. They're just kind of boring. Whereas the L-type channels are more interesting. So, funny channel, who comes in? Funny current to sodium. You get to threshold, what opens? Voltage gated. What's the ion? Eggshells are made out of it. It's rich, milk is rich in it. Calcium, thank you. Voltage gated calcium channels open. you get to the maximum depolarization, which is about plus 20 millivolts. Voltage gated calcium channels close, and voltage gated, who opens? Potassium channels open. Potassium now leaves the cell. You repolarize back down to resting potential. The resting potential is somewhere around 45, 50, minus 50 millivolts. And then the funny current, the pacemaker potential, starts again, and then you do it all over again. This is the electrophysiology of the pacemaker cell. Pacemaker cell. And so the electrophysiologist will give each of these phases different numbers. The numbers, unfortunately, don't make a lot of sense with this one. So the funny current pacemaker potential is called phase 0. The depolarization part where it gets more positive, that's called stage 4. Stage 4. And then when the potassium channels open, that's called phase 3. So it goes 0, 4, 3, 0, 4, 3, 0, 4, 3, 0, 4, 3. What happened to 1 and 2? These cells have no 1 and 2. When we get to cardiomyocytes, we'll see 1 and 2. But these don't have 1 and 2. They just have 0, 4, 3. 0, funny current. 4, depolarization. Depolarization is caused by calcium. Calcium is going to cause the cells to contract, remember? And then 3 is potassium leaves the cell. Calcium comes in, potassium leaves. I did that very fast. Are there any questions about that? I don't pretend this is simple. There's nothing about this. There's nothing about cardiology that's simple. I can try, sure. Let's do this one over here, even though this one doesn't erase. Then I'll make Brian erase it. That'd be fun. All right, so stage 0. That's resting. But you have the funny current. And so you have the funny current. That will then get you the threshold. When you get the threshold, stage 4 begins, and the voltage gated calcium channels open. You get to maximum membrane potential around about plus 20. Now the calcium channels will close and the voltage gated calcium channels will open. That causes you to repolarize back to stage 0. Brooklyn?
When potassium channels open, that's when potassium is leaving the cell, right?
Potassium will leave the cell. Since cations are leaving the cell, the memory potential will become more negative, and it'll get back down to resting. Okay. Some of you look a little glassy-eyed this morning. Perhaps it's cruel and unusual punishment to do electrophysiology, cardiac electrophysiology this early in the morning, but hey, it has to be done. Now, the pacemaker potentials, because the rest of the atrial cells are, you can walk over there and take a picture if you want.
I'm just sending it to Jacob.
Oh, you're sending him Jacob, okay. Because the atrial cells are connected to these cells, the atrial cells will pick up the signal to contract. Once they start contracting, they will all contract. What happens if the nodal cells are not the only cook in the kitchen, so to speak? What if you have other areas of the atrium that are asserting automaticity? Now, other cells in the atrium can do that, but because the SA nodal cells do this so well, they suppress any other atrial cell from being an ectopic pacemaker. If, however, there is damage to the SA node, now other parts of the atrium may start to assert itself, and that will generate what's called, that will produce an ectopic pacemaker. Now, instead of one signal to beat, you may have multiple signals to beat, and that can cause this phenomenon known as an arrhythmia. Arrhythmias refer to heart rates that are too fast or too slow or erratic. Too fast or too slow or erratic. If the signal to beat just keeps going around and around and around and around and around in the atrium, you can produce a so-called supraventricular tachycardia. Supraventricular meaning it doesn't come from the ventricle. If it comes from the ventricle, then it is a ventricular tachycardia. Let's now look at the action potentials that you get in a typical garden variety cardiomyocyte. So myocardial cells have a resting membrane potential of about minus 90 millivolts. That's a lot more negative than other cells. Other cells will have an average resting potential of about minus 70 to minus 85 millivolts. So they are depolarized to threshold by action potentials that originate in the SA node and then spread throughout the rest of the heart. Now, heart muscle cells have a capacity that you don't find in skeletal muscle cells. Namely, that when calcium is brought into the cell, it stimulates the release of internal calcium stores. This is called calcium-induced calcium release. Calcium-induced calcium release. This is unique to cardiac muscle cells. I wish to Pete they wouldn't have put this here because you probably can't see the board. You can? I'll bet you folks in the front row can. That really blocks everything. Frankly, I think this thing should be over there, but they didn't ask me. So as you can see, you have voltage-gated calcium channels. Calcium then will stimulate these calcium release channels that are in the endoplasmic reticulum. The endoplasmic reticulum in cardiac muscle cells and other muscle cells too is modified into a calcium storage organelle. That's why it gets called the sarcoplasmic reticulum inside muscle cells. Because it's one of its main functions is to store calcium. So you have this calcium release channel. These are sometimes called ryanodine channels because the drug ryanodine will bind it and block it. That's a drug that's used in research. So they are ligand-gated channels. The ligand in this case is calcium. Calcium binds to the channel opens. Calcium is now released into the cell. The calcium then binds to the troponin. Troponin gets dragged off the it drags the tropomyosin off the myosin binding sites on the actin. Actin can now interact with myosin. So the heavy band myosin now interacts with the light band myosin, and you get contraction. So here is electrophysiology of a cardiomyocyte. So here you also have several phases. Once again, the resting stage is called stage 4 in this case. You have a depolarization. That depolarization is caused by the leakage of ions, typically calcium ions, through the gap junctions. That will depolarize the cell. You will go from stage 4 to stage 0. At stage 0, voltage-gated sodium channels open, and they allow the very fast depolarization of the cell to its maximum memory potential of about below plus 20, plus 18, plus 16, something like that. Notice how fast that shoots up. It's very impressive. So the picture here shows you that for stage 0, it's sodium in. Sodium in because the voltage-gated sodium channels are opening. Do you have voltage-gated sodium channels in the pacemaker cells? No, you have a leak channel. A leak channel. That leak channel is for sodium. It's always open. This is different. So sodium rushes into the cell. You get this very fast depolarization. Then we go to stage 1. So we go from 4 to 0 now to stage 1. The voltage-gated sodium channels are going to close. Voltage-gated potassium channels will now open. Potassium will now leave the cell. You start to repolarize, but a funny thing happens on the way to repolarization. Now voltage-gated calcium channels are going to open. They have to open so that the cell has enough calcium to properly contract. Because without calcium coming in, you're not going to release those internal calcium stores to contract. But as these calcium channels open, that's going to slow the repolarization. That's going to cause this phase called plateau. Plateau. So now L-type calcium channels open. The voltage-gated sodium channels have closed. your voltage-gated potassium channels are opening. You'll repolarize, but you'll repolarize slowly. So this is now phase 2. Phase 2. So phase 1 is that dip down. Phase 2, we have the opening of the L-type calcium channels. Then over here at about 200 or so milliseconds, now those voltage-gated calcium channels are going to close. Now we get a very steep repolarization. That is going to be stage 3. Stage 3. And now, as we can see, those potassium channels will begin to close, and we'll get back to resting. When we get to resting, we're once again at stage 4. So we have 4, 0, 1, 2, 3. And so we have a 4, 0, 1, 2, 3, 4. That gives us these 5 different stages of the electrophysiology of the cardiomyocyte. So this is a right bit more complicated than the pacemaker. Let me go over that again. I think you got it. Stage 0, sodium in. What opens? No, that's with the pacemaker, with this cell. That really, really precipitous increase. What opens? Sodium channels, voltage-gated sodium channels. When we get to 1, stage 1, that little dip down, what closes? Sodium channels. Stage 2, the plateau, what opens? L-type calcium channels, L-type calcium channels. Stage 3, we start to get a more precipitous repolarization. Who closes? Voltage-gated calcium channels. And then down to stage 4, we're back down at resting, and the potassium channels at that point have closed. We're back at resting, and then we do it all over again with the repolarization and so on and so forth. And we go to 0, 1, 2, 3, 4 again. All right, questions? Now, if we overlay this with the muscle contraction, notice how the muscle contraction ramps up as calcium comes into the cell. And notice that the peak of contraction is essentially just before the L-type calcium channels close. Is that as it should be? And then notice relaxation essentially begins where the calcium channels, L-type calcium channels, close. That's pretty much what you expect, given the dependence of the cell on calcium to contract. Once the cell is done contracting, this pump, this so-called SERCA pump, sarcoplasmic reticulum calcium pump, the SERCA pump will very rapidly pump calcium back into the sarcoplasmic reticulum. There's no more calcium, and troponin is now going to change conformation. Tropomyosin is going to cover those myosin binding sites on the actin, and you will not contract anymore. And these are just some of the players. Some of these players are subject to regulation. So I don't want to belabor the point here, just to show you that the L-type calcium channels are subject to pharmacologic regulation. So are some of these other exchangers and things like that, sometimes directly or indirectly. Also, the SERCA pump, there's a protein called phospholambin that helps regulate that and what have you. So these sorts of things can help the cardiomyocyte pump faster if it needs to, or more forcefully if it needs to. And we'll look at drugs that do that. All right, before we get to the way conduction happens, are there any questions about electrophysiology of the heart? Yeah, Brooklyn? The reason the cardiomyocyte contracts after it gets a threshold is due to sodium influx because of the opening of the voltage-gated sodium channels. For the pacemaker, it's a slightly different story, but the funny current is sodium-based. So you could make that argument for the nodal cells. So once the beat originates in the SA node, you see the SA node is towards the top of that right atrium. The signal propagates down the atrium to special conductive tissue at the bottom of the right atrium called the atrioventricular AV node. That atrioventricular node will then conduct the signal to this conductive tissue that is in the septum of the heart. That is either called the atrioventricular bundle, or it's classically called the bundle of His. And my stupid mnemonic is that kind of looks like a snake. So the head of the snake, so the snake goes hiss. So it's a bundle of, snake says. So that's my stupid way to remember it, the bundle of hiss. And then that divides into what are called the right and the left bundle branches. And the left bundle branch will go down to the apex, swing around, and it will send the signal to the walls of the left ventricle. The right one will branch through the septum, swing around the apex, go around, and feed the walls of the right ventricle. Notice that there are small little branches that will feed the papillary muscles, so that the papillary muscles will contract in concert with the contraction of the ventricular walls. And there are tiny little branches of these right and left bundle branches that are going to essentially feed different parts of the heart. And those little branches are called Purkinje fibers. Purkinje fibers. So we go from SA node, atria, AV node, bundle of His, right and left bundle branches, down around the apex, they become the Purkinje fibers, and they feed the ventricular walls, muscular walls. Keep in mind, if you have any sort of myocardial infarction or anything like that, and you have dead tissue, now the conduction has to go around the dead tissue. If it goes around, sometimes the beat can do this and just go around and around and around and around and around and around and around, causing the tissue to now initiate a beat every time it goes around. That is called re-entry. Re-entry. So those are the two sources of arrhythmias, either some sort of ectopic automaticity or re-entry. Those are the two main causes of arrhythmias. How might you treat an arrhythmia like that? Any guesses on how you might treat it if a beat's going near like that? How might you treat that? Do you have any guesses? Just give me your best guess. You can use calcium channel blocker. Yeah, that would help. If you just slow the heart down in general, then usually it'll find a way around instead of doing that, because this requires it to go faster. So by just slowing the heart down, actually, you can actually prevent that. And that's why medicines that actually just slow down the heart rate can prevent arrhythmia sometimes. Little bit about the speed of conduction. So the action potential from the SA node will spread pretty leisurely, anywhere from 0.8 to a meter per second. Once it gets into the atrioventricular node, it's going to pause a little bit. That's to give the atria time to contract before the signal goes down to the ventricles. Once it gets into the bundle of His, it goes up pretty fast. So this delay, it goes from 0.8 to a meter per second to about 0.3 to 0.5 meters per second. Then it speeds way up to 5 meters per second once it gets to the bundle of His and the Purkinje fibers and so on and so forth. So it kind of goes tortoise, hare, tortoise, hare, tortoise, hare, kind of that sort of thing. I talked about this already, but I bring this up here just to let you know that the troponin that you have in cardiac muscles is specific to cardiac muscles. It's different than the troponin or tropomyosin you find in skeletal muscles. If you have a heart attack and cardiac cells die, they will release those proteins into the blood. They're markers for a heart attack. Those are one of the blood markers that you can find for a heart attack. And in fact, if you come to the ER with chest pain, they'll set you up with an EKG and they'll take some blood, because that's what they're looking for essentially, is troponin and cardiac tropomyosin, things like that. Cardiac contraction also has a refractory period. So while the action potential is occurring, that gives you this absolute refractory period. You then have a relative refractory period that you can cheat if you want the heart to go faster, of about 50 milliseconds. As you can see, that's pretty much toward the late end of phase 3. So you can cheat phase 3 a little bit. The reason you can cheat it is that you have two types of potassium channels. You have slow potassium channels and you have rectifier potassium channels. And you can, one of them actually opens, then shuts, and then reopens. The other just opens and stays open. The one that opens and shuts and reopens, you can cheat that. And that's why you can get a faster repolarization and beat a little faster if you want. All right, who here knows anything about EKGs? Two of you, okay? I'll take this slowly. Now that electrical activity from the heart can be measured. If you put electrodes on the skin, the electrical changes in the heart can be detected by those electrodes through the skin. Furthermore, by using the electrical profiles of the heart from electrodes that you put on different places around the heart, you can get an electrical snapshot of the heart from different perspectives. So for example, if you take a picture of the water bottle like this, and then like this, and then like this, and then like this, and so on and so forth, if, say, somebody ran over the top of the water bottle here, you have a shot of the water bottle like that, you wouldn't know that the top is damaged. It's only after you get a shot kind of like that, you'd see that the lid was gone because somebody ran over it. So by getting snapshots of the heart at different places, you can get a very, very good idea of where there's damage to the heart. That's why a 12-lead EKG is really the industry standard nowadays. Now, much of what I'm going to show you is one lead EKGs. They give you just a 2D snapshot of the heart. They're useful. They have their place, but they're simply not, they don't have the power of a 12 lead EKG. They just don't. So if we look at the myocardial action potential from the cardiomyocytes, and we see what that gives us essentially when it comes to what we'll record when we put electrodes on the skin, we get these series of waves that look like this. The first of those waves is the P wave. The P wave, as you can see, is relatively humble. That indicates atrial depolarization. Atrial depolarization. Following the P wave is an interval. That's called the PQ interval. And then you have this large wave called the QRS wave. QRS wave. Notice that this pretty much encompasses depolarization. So that represents ventricular depolarization. Notice how robust that wave is versus the atria. That gives you an idea of how much more powerful ventricular pumping is relative to atrial pumping. The T wave represents atrial repolarization. And notice how it correlates pretty nicely. The peak of it correlates nicely, essentially, with the onset of phase 3. So P, atrial depolarization. QRS, ventricular depolarization. The T wave is indicative of ventricular repolarization, getting that cell back to the resting potential. And so your EKG recordings, if you just want a one lead EKG, yeah. No, ventricular. Did I say atrial? Sorry, ventricular. So QRS and T both have to do with ventricles. P just has to do with atria. If you want a one lead, all you need to do is put a lead essentially on your wrist, and then you put 2 leads essentially on your ankles. That'll give you a really nice one lead EKG. It's easy to do. If you want a 12 lead, then you're going to take a look at the bipoles of the heart, and you're going to imagine 2 triangles like this. And so you'll have leads 1, 2, and 3, essentially going from the right arm, left arm, right arm and left arm, between the right arm and left leg, just like that, nice triangle like that. And then you'll have these leads that go over the chest that will give you snapshots of the right septal and left ventricle going through like that. And you essentially feel from the top here, and then you feel the different intercostal spaces. You go 1, 2, 3, 4. When you get to that 4th intercostal space, on large people, this is hard to do actually. So you start up here with the clavicle essentially. You then go down, and you, in fact, on yourself, if you do it, you can feel it. And then you go, oh, there's a heart spot. That must be a rib. There's a second one. There's a rib. There's the other third one. And sometimes you have to push a bit to find it, especially on people who do a lot of bench presses. But you can find it. There's a difference between bone and muscle. It has a different feel. And that's essentially where you put 1 and 2 on either side of the sternum. Once you get those 2 down, the rest is cake, essentially. 3, 4, 5, 5 for the left ventricle is kind of the money one, because that gives you the best snapshot of what the left ventricle in general is doing. And so as the wave of depolarization moves down the heart, you can see this with different colors. to have depolarization moving across the atrium. We see the formation of the P wave starting. Then as the atria start to repolarize, the P wave is done. It then starts to move down into the ventricles. We're now getting ready for ventricular depolarization. We go from the P to the start of the Q. We have depolarization of the ventricles, QRS wave, and then we start to get repolarization of the ventricles, and we make the T wave. And this correlates quite nicely with also the different stages, as we saw, of the cardiac cycle, where we have isovolumetric contraction, and then ejection, and then isovolumetric relaxation, and then the closing of the semilunar valves and diastole and so on and so forth. And these correlate nicely too with the heart sounds. At the trough of the QRS, you can see you get your first heart sound, and essentially in the midst of the T wave, you get your second heart sound. How does the EKG vary as a result of pathology? With a one lead EKG, if someone has had a heart attack, now there's two different types of heart attacks. There's what's called a non-ST elevated myocardial infarction, non-ST elevated myocardial infarction, and an ST elevated myocardial infarction. A non-ST elevated myocardial infarction, the infarction only occurs in the innermost part of the heart. It doesn't go all the way through the wall of the heart. So that is a less severe heart attack. With that, typically what you'll get is depression of the ST segment. If you have a STEMI, ST elevation myocardial infarction, now the infarction, the death of the myocardium, has gone all the way through. It's a full thickness infarct, sometimes called a mural, M-U-R-A-L, mural myocardial infarction. That is going to cause ST elevation. You can see the ST elevation nicely in lead V4, V5, V3, V2. Really, you see it in almost all these. But you can see the elevation of the ST interval really precipitously. This is a 12 lead EKG in a patient with a STEMI, where this would be a non-STEMI, an N-STEMI, this would be a STEMI. So our arrhythmias refer to abnormal heart rhythms, as we said. They can consist of hearts that beat too fast or beat too slowly. So your average heart rate is between 60 to 100. If you are an aerobic athlete, there's a good chance your resting heart rate's below 60. You'll have so-called runner's bradycardia in some cases. That's due to overactivity of the vagus nerve. I had Jeremy, oh, I can't remember his last name. Jeremy, he runs distance. Can't remember his name. Jeremy, I had him in class last year. We took his heart rate just on a chance. His resting heart rate was 49. So that's an example of a guy who does a lot of distance running. He's very good at it. He's very talented, and he runs a lot. So I asked him, so this weekend, what'd you, he said, oh, I took the weekend off. I only did 7 miles, you know. Yeah, rub it in, pal. So that's an example of a guy with runner's bradycardia. if you take a heart rate on someone and it's below 60, if they have heart failure or they've had a heart attack, then the heart is damaged such that the heart rate might be really low. If they're on certain medications that lower the heart rate, then the heart rate will be lower than 60. Otherwise, they might say, do you do a lot of running? Something like that. They might say, yeah. So then that's the case. It's not a big deal. If the heart rate's above 100, then they typically have tachycardia. Now, if someone's on a drug like Adderall or other types of drugs that increase the heart rate, then the resting heart rate typically will be above 100. That's not anything to worry about, but typically resting heart rate above 100 is tachycardia. So you can have heart rates that are really ridiculously high. Flutters can be between 200 to 300 beats per minute. Atrial flutter results essentially from the beat just going around and around and around the mitral annulus. It just goes around and around and around like that. So you essentially get a EKG where you'll get 4 P waves to 1 QRS, and the P waves have a sawtooth. Sort of thing like that. That's an example of atrial flutter. And then with fibrillation, you don't have one signal that tells the heart to keep beating. They're coming from multiple places in the atrium or in the ventricle or something like that. That causes fibrillation. We have an uncoordinated beating. That can lead to asystole, where the heart's not beating at all. If you get fibrillation like that, where the heart's really just quivering, giving the heart a shock, that's a shockable rhythm, as it's called. That essentially can reset the heart so that now we'll get back into normal rhythm. Okay, out of time, we'll finish this and then we'll get into the regulation of blood pressure and we'll get into medications. Today? No. March. Yes. Yeah. Because there's just one. It's out of 40.